Good morning, everybody. This is Cindy Mann at Manatt Health, and a few more people are calling in, but we've got a great crowd with us today. So very happy to be doing this with you. We are, let me first just introduce quickly the Manatt team, some of whom will be presenting during this webinar, and some of whom won't be, but all of whom have been deeply involved in the project. They include Naomi Newman from our California office, and Michael Chong, and also Jocelyn Geyer, and myself, Cindy Mann. And Jocelyn and I will be doing the presenting on this webinar, and as indicated by the fact that here I am, I'm going to start off. So thank you again for joining, and thank you, Michael, for turning to our first slide. So just gives you a sense of what we're going to try and cover today. We want to give you just a quick overview of the project, of the work that we've been doing together with the National Center for Medical Legal Partnerships, talk about what we've learned, mostly from all of you, about your funding streams, and spend most of our time talking about financing opportunities with Medicaid dollars, and then have time for questions and discussions and with next steps. So if we can go to the next slide, I can begin to talk to you a little bit about our project overview. So we've been working for a few months with the National Center and have been privileged, frankly, to do that. It's been a two-phase engagement, and the initial phase was a survey, consisted of a survey to really learn more from all of you, or from at least some of you as representatives of all of you, about how the funding is working now. We supplemented a written survey that went to about 14 MLPs around the country with a focus group, really a call, with 18 MLPs, where we dug a little bit deeper into some of the information around financing that we had gathered through the survey. We have, in the meantime, been doing some research on ways in which MLPs can pull down other sources of funding, some of which you are pulling down now, some of which would be new to MLPs. And today's focus is to provide some results of our findings and our research through this webinar, focusing mainly on Medicaid. They are not the only funding streams, but we thought they are particularly promising at this moment, and maybe least understood. So we wanted to go through those and spend most of our time in the webinar today talking about them. But just as a quick overview, medical legal partnerships around the country provide very different levels of legal services, and they are largely, some of them focus more on one area, some of them are multi-area set of services, mostly centered around the iHealth framework. And if we can go to the next slide, what we learned a bit about the funding streams that currently exist is that the majority of MLP's funding is from their health partners, their healthcare partners. They're from their operating budgets of their healthcare partners. In some cases, we also have some MLPs that are connected with community health centers, FQHCs, and there's some health center HRSA funding that is part of helping that arrangement work. We also have some MLPs that have philanthropy, other kinds of state and local grants. What we found, not frankly to our surprise, is that direct Medicaid funding is rare. And what we found, again, not to our surprise, was the sustainability of financing streams is a real concern across the MLPs throughout the country. So none of that should be a surprise. It's just a level set where we're going from here. And if we can go to the next slide, we really do think that there is a particularly opportune moment that we're all in right now to think about how to tap into some of the financing streams that are available to Medicaid. And as I said before, our focus today on this webinar will be on those Medicaid sources of funding. We're going to go a little bit into a deep dive on them and give you full legal sites, because we know you guys are focused on the details and will want to do some of your own research following this webinar. But we also don't expect this webinar to leave you as Medicaid financing experts, and that's why I just want to flag that there are next steps that the National Center is planning to really help continue to provide information and support to MLPs as they pursue Medicaid funding and other sources of financing to stabilize and hopefully grow services. But let's talk a little bit about why the time is ripe right now for exploring Medicaid streams of funding. We are really seeing across the country an increased focus on social determinants of health and the ways in which those social determinants of health will impact people's ability to be or become healthy, as well as impact on healthcare costs. So currently, we've done a review of Medicaid managed care contracts. Most states, as you know, deliver Medicaid services for at least a substantial portion of their populations through managed care. And when we reviewed the contracts between states and the managed care plans, 35 out of 39 states with managed care require or encourage their managed care organizations to do something around social determinants of health. And that is actually only growing at this point in terms of both the expectations that states have for their managed care organizations as well as the number of states that are actually jumping in and doing this. So what we're really seeing is, well, I don't know, maybe in the last few years there were pilots, there were different efforts in different parts of the country to really start to think about interventions on social determinants, with some states really taking the lead. What we're seeing now is that we are well past the fad stage, and a much larger group is jumping in, and they're jumping in with both feet for the most part, not all states for sure. So all of this means that this presents an enormous opportunity for MLPs to demonstrate that legal services can really effectively address social determinants of health, and that it can really align with, we put here, the funder's objectives. That could be the MCO itself, could be contracting with you, and we're going to talk about ways in which they have dollars to do that, or it could be through the state itself, through certain kinds of Medicaid benefits, or potentially both. So I think there is a strong appreciation in Medicaid agencies of the effectiveness of legal services and medical legal partnerships. At least over the years, they have certainly come to rely on legal services for lots of things that they're looking to move forward. I remember years ago, lots of states were contracting with legal services to help people move from welfare payments to federally funded disability payments, for example. So I think there's a real appreciation, and increasingly states are really thinking about when they're doing interventions and funding or encouraging or requiring their MCOs to do interventions, that they want the loop to be closed. They want something more than just a referral to a service. And medical legal partnerships are notoriously good for closing that loop and really delivering the service for people that they need. So if we can go to the next slide, I'm not going to walk through this in any detail. You've probably seen it in different contexts. But the activity around the country is really spurred by a growing recognition of the impact which socioeconomic factors have on health and health outcomes, and also on healthcare costs. So the trajectory of some of the interventions in the Medicaid program around these issues has been really starting with the high needs, high cost, complex adults, and that is often still where the focus is, but increasingly we are seeing states step back and say, well, wait a minute, these kinds of issues are really important for driving better health outcomes and potentially lowering costs, but certainly to drive better outcomes for other populations. So some states are taking a broader lens on their social determinants interventions, and some states are more narrowly focusing it on high cost, high medical needs adults. So if we go to the next slide. To access, I think we, oh, you're right, sorry. So we've divided up the categories of possible funding sources from Medicaid into 3 buckets, and we're going to go through each of these 3 buckets in the webinar. One is the bucket of state plan authorities. So state plan is the legal agreement that a state is required, if it's going to participate in the Medicaid program, to complete and keep up to date. They're publicly available, although sometimes it's a challenge to find them. And it lays out their definitions for which benefits they're, well, it lays out which optional benefits they're going to pick up. All states obviously have to do mandatory benefits, and it also lays out how they define those benefits. And in some cases, there's considerable discretion on how they define those benefits. And some of those benefits, particularly case management and care management, Jocelyn's going to talk about, give significant authority to use Medicaid dollars to pay for some of the interventions that are part of the social determinants of health package of interventions that are commonly relied on. In addition, and perhaps even more opportunity lies within the premium dollars, the Medicaid premium dollars that are paid to Medicaid managed care organizations, MCOs. They have a fair amount of discretion under federal regulations as to how they use those dollars. It has different implications for rate setting and medical loss ratio and other things, but considerable discretion, and we'll go through that too. And then finally, there's the area of waivers, 1915C waivers and 1115 waivers, and we'll talk a bit about that and a couple other sort of more unique opportunities in the CHIP program and through CMMI.
Great, thanks, Cindy. I'm going to walk us through 3 of the major opportunities in Medicaid to get coverage for at least some portion of the activities that you do. Spoiler alert, there's only one of these that will straight up give you a chance to cover some direct legal representation costs. And I'll flag which one that is at the end. So the first thing we're going to talk about is case management. And Michael, let's go to slide 12. And case management, as Cindy said, is an optional benefit in Medicaid. So the beauty of case management is any state can decide they want to provide case management services to their beneficiaries, and that is really helping them to gain access to various Medicaid social, educational, and other services. So whether you're a fee-for-service state or you're a Medicaid managed care state, your state can go ahead and add this service. It doesn't have to, but it can. And most states do have case management for higher need beneficiaries, folks with behavioral health conditions, those kinds of things. And I think the reason we wanted to lift it up and talk a little bit about it is because that activity of doing an assessment of what someone needs and thinking about how to connect them to various services is sometimes a key component of what you all do. It can be the first step when someone is coming in the door. So create some options to essentially get Medicaid funding for at least that portion of some of your services. A couple key things about case management. This is not, unlike some of the other options we're going to give you, where there's a lot more flexibility at the plan or the state level. Because this is a Medicaid benefit, there's distinct parameters around it. So in order to give case management to someone, there has to be a comprehensive assessment of what they need and periodic reassessments. They need a care plan. It needs to entail referring them to the social supports around them that they might need in monitoring and follow-up. So it's relatively well-defined as these things go. Just another caveat, a number of years ago, I think it's actually decades ago now, there was an effort and controversy around the extent to which states might have been using the case management benefit to refinance activities that could have been paid for through other sources, and we started to get GAO reports and OIG looks. And so there is now some clearer language that you'll see at the bottom half of slide 12 that essentially is trying to make sure that case management is only used when there's not other sources of funding to cover the activities, that we're not paying for it twice as a separate service, but also as part of maybe a long-term services. And so you'll see that that's part of what has evolved with this benefit over time. That said, we think that it is an opportunity, an important thing to look at and to see if a portion of what you do can fit under the case management rubric. And the underlying premise of all of this option and the other two is we could get Medicaid managed care matching funds for it. So if we could do that, that creates a much more sustainable financing approach. Michael, let's go to slide 13. On slide 13, we wanted to give you a flavor of what case management can look like. And if you have case management in your Medicaid program, it's because your state has filed a state plan amendment that says, we do want to cover this benefit, and here's how we're going to do it. So on slide 13, we've given you some examples of states that have covered it, a little bit of a flavor for how they've gone about defining it and fleshing it out. So, for example, you'll notice New Hampshire is a state that not only added the benefit, but then said things like, we expect this case management to occur face-to-face periodically, and that's in response to increasingly we've seen sometimes folks just do telephonic case management, and it doesn't have the same effect. So within the federal parameters, there's some direction that the states can give. And this is just to give you a flavor if you want to see some of the language. The SPA numbers are very helpful. And I know especially maybe for the legal folks on the phone, it's useful to go see the specific language. So would encourage you to take a look at that. Okay, so the next option that we wanted to talk about has a little bit more flexibility to it, but it only works if you're in a Medicaid managed care state. So in the context of Medicaid managed care, when states decide how much to pay plans for delivering services, they pay them for the covered benefits, which could include case management, and they also pay them for something called care management. And so that money that goes to the Medicaid managed care plan is matched by the federal government. You've got some federal funding behind it, relatively sustainable. And the option we wanted to lift up and explore a bit with you is that care management. So the care management is not a benefit. So unlike case management, there's not a lot of like, this is what it absolutely means in terms of a benefit. Instead, it's an expectation that the managed care plan will organize and coordinate care for folks, especially people with more significant needs. So what we've done on slide 14 is give you some of the statutory regulatory framework for care management and a couple things just to flag. So there are some minimum standards, even though it's not a benefit, there's still some in federal regulations that I believe Cindy put out and wrote. There's still some standards around what has to be part of care management. And so if you're doing care management as a managed care plan, you need to be screening people to figure out who needs help. When you've got someone who needs help, you need to designate a coordinator, a person who's going to think about coordinating services for the individual across settings, with other payers, and with community and social support providers. And if you're doing care management for a high needs person, so someone who needs long-term services and supports, or who has a special health care need, then there needs to be a comprehensive assessment done of that person and a care plan that goes with it. I will flag that special health care needs is a wide open category, so your state could decide, and we're going to give you a few examples, like in North Carolina, they consider people with significant unmet social needs, regardless of their health status, as a population that requires more intensive care management. So lots of state discretion there. And again, this isn't a slam dunk, right? Like this isn't exactly what you do, but it's a piece of what some of you do. and it can be built into the Medicaid managed care contracts and into the Medicaid financing structure. So Michael, let's go to slide 15. And part of why we wanted to lift up care management is we are seeing states being increasingly aggressive about using it as a tool for tackling social issues and some of the kinds of issues that you all address. So North Carolina is definitely the current state that's leading the way, we would say, probably across the country, in terms of social determinants of health, and you can see it in how they've approached care management. So in their contract with Medicaid managed care plans, as part of the care management obligations, they are clear that the plans need to, under care management, provide some peer support to folks who may need help navigating services, to give them some support as individuals to increase their own capacity to manage working across systems. The plans must make sure that if someone needs SNAP or other government benefits and they can't get through, that they will offer in-person assistance. So not just that phone call, but like sit down and work through the application and the documentation requirements. They have to have a housing specialist on staff to help their beneficiaries, to support their staff in helping beneficiaries navigate housing challenges. And they need to help beneficiaries access medical legal partnership for legal issues that directly affect their health. I will say there was a lot of kind of debate over this language and how far it could go. The language does not say you must pay for medical legal partnership, which would have been like the mecca, right? Care management can't go that far, but it can set up a very clear expectation that the connection between medical and legal issues is a part of the equation of what needs to be handled and navigated on behalf of beneficiaries, especially those with more expansive needs. So an opening here, and we're going to hear from a few of you who've been working directly kind of through these routes in a little bit to see how it plays out on the ground. The last Medicaid tool I wanted to cover, which is, they've all got ups and downs. This one, the big up is, I think it actually could straight up finance some of the legal costs associated with medical legal partnership. The downside, as we'll talk through, is it's optional for plans. They don't necessarily have to do it. There's not as solid a kind of clear funding mechanism for it. So let's go through this one. So value-added services in Medicaid managed care, that's essentially states pay plans a capitation rate to cover the legally required services plus do care management. They have the option, of course, if they have money left after meeting those basic obligations, to go ahead and do what we call value-added services. So services on top of what's required. And traditionally, this has included things like bikes for kids or car seats or gym memberships, and we still see that frequently with value-added services. But increasingly, we are seeing states, and again, North Carolina is probably the poster child on this, doing much more to direct what the value-added services look like, and we're seeing more and more plans as the focus on social determinants of health continues to rise, looking to provide value-added services that are directly related to connecting people to housing, even paying for housing in some instances, getting them food. And so we think this is a really interesting area to push on, especially, as Cindy said, given that states do see the value of what you do and do see, for example, if you can work with a landlord on a housing issue, it's a lot cheaper than them having to figure out how to rehouse someone whose physical health may be at stake in the absence of some steady, safe housing. Just a little bit more on this, because it really is a pretty ripe area. When you first hear about it, it's sort of like, oh, great, of course, if they feel like it, they could do something useful, like pay for medical legal partnership. But I think that's increasingly not the way to think about it. It really is, especially with states stepping in and saying, when you bid in our state to get this huge Medicaid managed care contract, very valuable contract, part of what we're going to look at is what are the value-added services you're offering. And we have seen some states straight up offer more points in the procurement process to plans that are offering services they care about. So Louisiana, for example, it's actually not a medical legal partnership, but the example holds they want dental care for their adults. They don't cover it as a benefit. If their plan bid and offer dental care, they give them more points. So needless to say, every single plan does it. So if we can kind of use the momentum around the focus on social determinants, the value of medical legal partnership, and start to work with states to say, hey, this is a key thing you should be looking for. Certainly ask for it when you're doing the process of selecting your managed care plans, and even think about saying you will give the plans that provide it and related services a competitive advantage. And that turns out to be extraordinarily powerful because the managed care plans really care about winning their procurement bids. It's how they stay alive and flourish. So that's kind of an interesting one, and we would encourage you to keep looking at that. So I'm going to wrap up with kind of the strategic implications on this, and then we're going to turn it over to a few of you who've been doing this on the front lines to talk it through. So Michael, let's do slide 17. As we thought about what this means in terms of very practical strategies, a few thoughts for you. One is to engage in and look at as much as you possibly can with all that you have on your plate already, the managed care contracting process, and take a look. Is your state requiring coverage of case management? Is it like North Carolina when it comes time to defining what the care management obligations are? Is it including and talking about the importance of medical legal partnerships as a key partner? And then I think probably maybe most intriguingly, is it straight up saying we will give you a competitive advantage as a plan if you agree and offer and pay for some of these important social services, including medical legal partnership. I will say that sometimes it can be hard to do like a blanket, like that we want to see medical legal partnership in general. It could be more a target population that's really important to the state. So behavioral health population, opioids, folks affected by opioids, or kids with asthma. We want to, tell us, the state could say, tell us what value-added services you will provide to address kids with asthma who are in housing that's not safe, or, it could be a variety of things. In terms of, so that's sort of the short term is attunement to that managed care contracting process. And then a little bit longer term, to really look ahead and see if you can get some of those optional benefits added in terms of case management, and then just push on those definitions of care management and that structure around the value-added services. Okay, let's go to slide 18, and these are kind of additional thoughts on things to look at and research, and just to have under your belt as you figure out a Medicaid strategy if that's something that you're pursuing. So the first is we do recommend doing the basic background research. Where is case management? Is it in your state plan? Is it not? Is it something that's on the horizon? Is the definition of case management written in such a way that you could fold under it some MLP services? Take a look from the research perspective, if you're in a managed care state, at that procurement schedule so you can start thinking about how you might affect that. And we do often see states issue draft contracts and give you a chance to comment. So generally attunement to that can be useful. The second thought is to really look at that value proposition, which is a theme that runs throughout this conversation. But as much as we can fold medical legal partnership into a key part of the effort to address social determinants of health and to address populations of significant concern to the individual states, and that's a cost-effective way of doing it, the better off we will all be. And then the last thing, if you're in the positive situation of having gotten some reception to the advocacy and the ideas, then it becomes important to turn and look to payment approaches. And we're going to talk a little bit about that here, but it also is, I'm sure, worthy of its own longer conversation and probably additional webinar. So, but we have seen both some fixed amounts for medical legal partnerships from managed care organizations, as well as in a few instances, some fee-for-service payments. And with that, I'm actually going to turn it over to Indiana Legal Services.
Hi, this is Jay Chaudhary from Indiana Legal Services.
Ah, wonderful. Do you want to jump in? You'll do such a better job than I will. Thank you.
Sure, no problem. Thanks. So just, really quickly, so just to understand the context, Indiana is obviously a deeply conservative state. Nonetheless, we did expand Medicaid in our own special way, which now is maybe the model for the whole country, unfortunately. So sorry about that. So we had, it's a managed care state, so we had funding from a different managed care entity. This was kind of more in the traditional MLP sense, like it was sort of site-based at these clinics, and we were to serve the entire population of these 4 community health clinics. And, it was just run like a traditional MLP. We would get referrals from the people on site, do the casework, and, we did, I think, some pretty good work, but unfortunately that managed care entity was acquired by a bigger one, and in that process they, cut a lot of discretionary spending, and this was one of the things they cut. I think we're still in a holding pattern about what the future holds. I think they're interested in renewing it, but we'll have to see. So luckily for us, right as that was all happening, we were approached by Anthem, who's the largest RCE in the state, about providing or about starting MLP. I think they had seen the writing on the wall in North Carolina, and we're hoping to sort of maybe pilot something here. And so this has been an interesting project. They just, they cut us a check and said, it's open to the entire Indiana Medicaid population, regardless of who the MC is. There's 4 of them here in Indiana, and they can all access these services. The vast majority of our referrals come from just sort of community partners, and we just gather sort of additional information about who their MC is, and right now we're just warehousing it because we're not sure how to transmit it, which is kind of an issue. But it's different. One of the main differences is this is not in any way physically based in any location, which has been a challenge because there's no sort of frontline staff to train and identify to make these referrals, and so we've just been using it as more of a catch-all program because the vast majority of our clients are Medicaid eligible anyway. So that's been, interesting in terms of just training. We've gotten 4 referrals from Anthem directly. We've got 30 or 40 from other places that we're counting in this project. And honestly, they seem okay with it. I think they're looking for a minimum viable product more than anything. But an idea that we've had and what we're kicking around right now is to sort of simplify things. I think earlier was mentioned, how do you draw lines with populations or issues? I think we're looking for years 2 and 3 to sort of simplify this process by focusing in on housing cases, because that has sort of direct correlation with health. And we think it might be easier to train the Anthem staff. Anthem has an army of community health workers here in Indiana, and I think it might be easier to train them on that particular issue. And then so we're exploring some creative financing mechanisms like social impact financing to see what we can do there. Sort of kind of the last point, and it goes directly into knowing where you are, the landscape where you are. Indiana is launching work requirements. I'm sure most people are aware of it. And, without commenting on whether or not that's a good plan or anything like that, we have made the point to the state, and it's been received pretty well, that a lot of MLP services correlate directly with work, whether it's expungements or driver's licenses or other reentry type issues. And so we're encouraging our MCE partners to include whatever legal services we provide as part of their report to the state about what are you doing to help people get to work. And so that's just a point to just be mindful of the landscape overall. So that's really about it. I hope that was helpful.
That was great, Jay. Thank you. And with that, let me also present an opportunity, though I know you are already on to the opportunity. You can shoot questions to us and to Jay and others who are presenting through the chat function, and we'll go through some of those and work on the Q&A. So use the chat function for that, and we'll refer to it as we go forward. And sometimes Michael is watching it and can put out fires if there are fires to be put out in the short term. So just going to the next slide, if we could. Thank you. Thanks again, Jay. And I'm wondering if Marissa Ban is available. Michael, if you could turn the next slide to slide 20 to talk a little bit about what's going on in Delaware. Marissa is the MLP supervising attorney for the MLP at Delaware Community Legal Aid Society.
Yeah, hi, good afternoon. Can everyone hear me?
Yep, hear you great. Thank you.
Okay, great. So we have several different MLPs partners in Delaware, one of which is the state's Division of Public Health. So we've had a long-standing relationship through that MLP with the state. Another of our MLPs, just to give you some background, is a large hospital system in Delaware. Recently, the new medical director at our state Medicaid agency moved from that same hospital system. And our executive director happened to hear her speaking on social determinants of health and was able to talk with her about bringing MLP to the Medicaid population. So it was sort of a combination of being a small state and being in the right place at the right time and building relationships. But after that, we did a brief presentation. We have regular meetings with the Medicaid administration a few times a year to talk about some system issues that we're seeing. So we did a presentation there, and then we're able to schedule a meeting later to really take a deeper dive into how would we fund such a program. And what we're looking at this point is incorporating it potentially into MCO contracts for them to then do the services through like the in lieu of or value added dollars. So we're still in the beginning stages, but that's what we're exploring right now. Our next steps are to do some presentations with some key players at the MCOs and then do some needs assessments with them to determine what kinds of needs they're seeing once they've been made aware of what MLP is and how incorporating that into their services can help address the social determinants of health.
That's great. Thank you. And I think it also shows that you can really start to make those connections through just community-based meetings, doing talks at different conferences. Sometimes, you know, you wonder, why am I doing this talk? And somebody's in the audience and says, there you go. It makes a lot of sense for whether it's the managed care folks, the care coordination folks, or the state Medicaid folks. So good linkage made there. All right, I'm going to pick up on where Jocelyn left off and talk about another group of funding opportunities that are probably not quite as sustainable or steady, let's put it that way, as some of the ones that Jocelyn talked about a minute ago, but that still can be really important. So we put them under the rubric of Medicaid special funds. So if we go to slide 22, please, thanks. The first one I'm going to talk about is derived from the CHIP program, the Children's Health Insurance Program. And CHIP, as you may know, is authorized under Title 21 of the Social Security Act, and it provides matching funds, just like Medicaid does, but up to a cap. So it's a capped amount of funds for kids and children's health coverage. And some states use it in a Medicaid expansion to fund their Medicaid expansion for kids. Some states have a separate CHIP program. Some states have a combination. Regardless of how your state uses CHIP dollars, and every state uses CHIP dollars in one of those ways, regardless of how your state uses CHIP dollars, there's an opportunity that is often underappreciated, although some states it's been picking up a little bit over the last 5 years, to use some of their CHIP dollars for what's called a health services initiative. And basically a state can use up to 10% of their coverage expenditures, so no more than 10% of what they're spending on actual coverage, can be used for non-coverage. So non-coverage includes certainly their administrative costs for running the CHIP program, but it tends to be much less than 10%, and they can use the balance for an HSI initiative, and they can have more than one HSI initiative. And basically, it's a lot of discretion given to states to define it. It must be aimed at improving the health of low-income children. Doesn't have to be Medicaid-eligible children, doesn't have to be Medicaid-enrolled children, doesn't have to necessarily be CHIP children, CHIP-enrolled children, but it is a focus on low-income children, and to advance the state's public health objectives, as I noted. You get the higher CHIP matching rate, the state gets the higher CHIP matching rate for those services. So if you're in a state where a state is not spending all of its CHIP dollars, so there's a cap on the amount of CHIP dollars the state can get, the state's not spending all of its CHIP dollars, which is often the case, you can look into whether a state may be interested in doing an HSI. And again, they may already have an HSI, but they can have more than one, and some states do have more than one. If you turn to slide 23, Michael, gives you a couple of examples of CHIP HSIs in 2 different states that are around, they aren't MLP, and so you can get a sense. Massachusetts has HSI funding for after-school programs. Again, it couldn't be just for all after-school programs. It would have to be for initiatives in after-school programs that are really focused on low-income children. And in Massachusetts, they have the HSI to address youth violence, trauma, and to promote healthy development. In Oklahoma, in 2008, so relatively recently, CMS approved HSI funding to help boost the number of kids, the percentage of kids who were getting well-child visits and receiving standardized developmental screening. So again, it's like we talked about in the Medicaid context. It's not going to call out, you can use HSI for medical legal partnerships, but there can be initiatives for the HSI which will overlap largely, partly, with the kinds of services that you can make available to the low-income child population. And I should mention that CHIP HSIs are not a waiver. It's a state plan amendment that's easier for a state to do. There's a template to fill out, and it's not necessarily a big lift for a state to be moving in that direction. So next 2 that I'm going to talk about are a little bit of a bigger lift for states. So the national office, I think, sent a national center sent around to everybody some information about this new CMMI initiative. CMMI is the Center for Medicare and Medicaid Innovation, and it was created by the Affordable Care Act, and it gives this new office money that it then makes available through grants and other kinds of funding opportunities for different kinds of payment arrangements and delivery system models. And frankly, they have mostly been focused on Medicare over the years of CMMI. but on occasion they delve into more of the Medicaid space, and this is one of those occasions. And they recently put out a funding opportunity for providing integrated care for kids. And it's a lot of the focus in the language is around opioid epidemic, but the set of services, if you read the initiative, is certainly broader than that. And it's a 7-year funding opportunity. They're going to pick 8 states. States have to apply for this, and the application deadline is June 10th. So we don't know all the states that are going to apply, but you might have inquired based on the National Center putting out the notices with your state as to whether they're planning to apply. If you don't know if they're planning to apply, you can find that out potentially and be part of the planning process. It's getting a little late to be part of the planning process, but maybe not too late. But in any event, if your state is awarded an INC funding opportunity, then there may be a significant opportunity to partner with whoever is the lead organization. They require there to be a lead organization that partners with the Medicaid agency, so you can be in conversation with that lead organization and think about ways in which medical legal partnership services can be folded into the initiative and really enhance its ability to be effective. So next, if you would turn to slide 25, I want to talk a little bit about 1115 waivers, which are the talk of the town these days. So 1115 waivers are under Section 1115 of the Social Security Act. They can be very comprehensive waivers. They're for an experimental pilot or demonstration, and as you may be aware, because there's been litigation around recent 1115 waivers with respect to the work requirements, they must be found by the Secretary to assist in the promotion of the objectives of the program. It basically can allow a state to use their Medicaid dollars in ways that otherwise wouldn't be allowed. So Jocelyn went through a lot of the ways in which Medicaid dollars can be used for some or all portions of MLP services, to the extent that some of those services are walled off from regular Medicaid funding. You could think about the 1115 waiver as maybe filling in those gaps, but also it just can provide additional dollars. So even if it can, you could find some funding sources under care management or case management, the 1115 waiver, to the extent that it brings new dollars into the state, could just expand that pie. I will mention that in the 1115 that was recently approved for North Carolina, Jocelyn referred to some of the activities in North Carolina. Specifically say not for legal services. We don't think that means, North Carolina doesn't think that means that you can't, again, connect MLP to the efforts, but there may be limitations on what the waiver dollars can be used for. And with that, I thought if Gerson Soto and Eve Rubel are on the line to jump in and talk a little bit about how they're able to leverage some funding that has been made available through a California waiver. Are either of you on the line?
Hi, this is Gerson. Eve, are you there?
Yep, we can hear you. Thank you.
Excellent. So yeah, I'll start. I think Eve, are you on the call also? If not, I can start. So yeah, definitely from the legal partner perspective, it was great that we were able to really become involved very early on in the process of getting this application together for the waiver opportunity. I think the fact that our legal partners have sort of that expertise and that relationship. I know our office specifically had a very good relationship with the Department of Health Services and their then director, Dr. Mitch Katz, so that there already was an understanding of the potential value of legal services and the need that existed within the population. And given sort of the challenges with sort of the geography and the types of patients that we need to serve through this project, we ended up coming up with a pretty creative model where we sort of have an online portal to take referrals electronically and also work in person at one of the local outpatient centers. And I know we're running short on time, but I definitely want to also highlight I think here in Southern California, we have a collaborative of other medical legal partnerships that were involved from the very beginning in working with DHS and formulating what this plan would look like. And I think that's what's led to our early success is really the integration and the partnership on even from that very, very early stage. I know from what I understand on the county side and getting that waiver application up to the state, I think that was particularly helpful.
Absolutely. Okay, I'm going to keep us going because I see we are at the top of the hour, which is supposed to be our closing moment. So we can hang on there a little bit if other people can, so we can at least talk a little bit about next steps. But we are at the final slide on or the final substantive slide on key takeaways. This pretty much repeats some of the messages we had before, but let me go through them quickly, which is this really is the opportunity to get involved. And I know we've given you lots of information, and maybe some of the research activities would be new to you in terms of looking at state plans or looking at your Medicaid managed care contracts. But we're also confident that you're pretty engaged in the general conversations around the Medicaid program and with some of your managed care programs organizations around the state. So this really is the moment. And when I say this, I don't mean you have to do it today, but things are really gearing up, and the more you can get involved in those conversations and see where the opportunities are. You really have such a great track record. You know, there's no question you have a really important set of services that can contribute to the success of whatever a state or managed care organization is attempting to do around social determinants. It'll demand some resourcefulness. The way we've mentioned a few times, the importance of framing your services in terms of the Medicaid's responsibilities and goals, the managed care organization's responsibilities and goals, and the extent to which you're going to be able to fit some of your services into Medicaid funding will really depend upon which funding source you use. So you're going to have to be mindful of that. And as Jocelyn mentioned before, pricing, and I think from Indiana as well, pricing can be a challenge. It's a little bit of a different world for MLPs and health systems and Medicaid managed care organizations think about paying for services in different kinds of ways. I do want to mention something that we didn't mention before, is that when you look at a definition in case management, for example, in the state plan, you don't need, of course, I think people understand this, but let me just say it, you don't need to be, an MLP doesn't need to provide all of those services. When there is a state plan benefit or when there is a waiver benefit or service, it is often provided by a number of different organizations. So don't feel like, oh, I only do this, I don't do these 5 things, I do these 3 things. That's fine. You're going to be part of providing a larger cluster of services. And, sustaining fundings from these sources may present some challenges, although some of them can be a really much more of a consistent source of funding. So let me jump to next steps, if we could, Michael. I know we're running out of time. We worried about that. We had a lot to convey. We will look through the questions that have been coming up through the chat and providing some answers. There aren't a lot that have been coming in, but we'll respond to the ones that we can. One question that was asked is whether the slides will be available. Yes, they will be available, and the National Center will be distributing them. So if you look at the next steps, this gives you a sense of that this is not the end of the story. This is really the beginning of a new chapter in terms of the National Center, or beginning of new chapter, not a new book, for the National Center to really be providing some additional resources along the lines of this webinar. So they're going to be having some office hour sessions in June and July where the questions that you might have, both generally from the webinar, but very specifically relative to your state, may come up. and you can sign up and for the email updates, and that will also tell you when the office hours are scheduled. So please do that, and the National Center will also be sending an email to all of you with links to the resources, asking for some feedback on the webinar, please. We encourage you to do that, and other suggestions you have for follow-up. And there's Ellen's email address for all of you to send some additional questions, both about follow-up but also about the substance to the National Center, and we will all collectively do our best to respond to them. So I want to do a special thanks to our MLP colleagues who jumped in the webinar today. It always is helpful to hear directly from people in the field that are working their way through this, and I think we'll take advantage of their generosity and do some more peer supports as we move through this process. Thanks again to the 18 MLPs who joined us on our call and those of them who also filled out our survey, and to all of you for joining this webinar today. Thank you.